Today's lecture will be on the glenohumeral joint. The glenohumeral joint is composed of two main structures. First, we see the glenoid fossa, or the glenoid cavity, which is located on the scapula here. And then, of course, the head of the humerus here. This forms a multi-axial ball and socket joint. Other structures that we should mention is the connection between the acromion process of the scapula and the head of the clavicle, the subscapularis fossa, where we'll see the subscapularis muscle lie, the deltoid tuberosity, which is the insertion point for the anterior, middle, and posterior fibers of the deltoid, the greater tubercle, where we see a lot of the rotator cuff musculature attached to, and the lesser tubercle. When we're looking at the overall side view of the glenohumeral joint, what we're looking at here first would be, this would be looking at the anterior portion, and this would be the posterior portion. So the weakest part of the shoulder joint would be the anterior, and where we see impingements or complications or dysfunctional patterns that occur usually in the posterior department. If we look in the posterior side of the glenoid fossa, we can see that we have a lot of structures coming in, such as the supraspinatus, infraspinatus, teres minor tendon, which are going to attach to the greater tubercle. We have the subdeltoid bursa, which lies directly underneath the posterior fibers of the deltoid. And these are all forming a very structurally sound, protected area, whereas the only thing that we see that is protecting the anterior portion of the shoulder are going to be the glenohumeral ligaments. When we're looking at glenohumeral ligaments, they provide stability. The most important aspect is that they're providing stability when they're in excessive ranges of motion. So what this picture is trying to illustrate is a very slack system where we see at rest the superior, the middle, and the inferior glenohumeral ligaments have a lot of laxicity. We go into extreme ranges of motion. First, we'll talk about the middle or the anterior glenohumeral ligament. These are going to fire when the shoulder joint goes into excessive external rotation, AB, abduction, or horizontal abduction or abduction. When we're looking at the inferior fibers of the glenohumeral ligament, these are only going to fire in excessive ranges of motion when we're dealing with internal rotation, adduction or adduction, and horizontal adduction. So the one that's most often affected is going to be the middle glenohumeral ligament. When we see throwing motions, we see excessive external rotation, abduction. Again, as I mentioned, the ligaments are quite lax until the extreme ranges of motions are reached. This increases the overall mobility of the joint. However, when we're looking at the diarthroidal joint or the multi-axial ball and socket joint, we see that it also has large amounts of synovial fluid. So as we go around, this would be the synovial membrane. And then inside of that synovial membrane, we would have the synovial fluid. As mentioned earlier, when we're looking at the posterior side, we see the supraspinatus, the subdeltoid bursa, the deltoid muscle, infraspinatus, and teres minor are all coming from the posterior compartment. As far as ranges of motion are concerned, when you're talking about the glenohumeral joint, it's very important that you understand that the glenohumeral joint, its main ranges of motion are between 0 and 90 degrees. Once we go above or greater than 90 degrees, then we start to add the shoulder girdle or the effects of the scapula. So when we're looking at, for example, forward flexion, the majority of the movement that's occurring from 0 to 90 degrees in the glenohumeral joint is going to be alignment of the head of the humerus with the glenoid fossa. Once we get the alignment from 0 to 90 degrees, then everything from 90 degrees to 180 degrees will be aided by the larger muscles of the scapula and the deltoid. Same thing when we're looking at a frontal plane, when we're looking at abduction, we'll see that rotator cuff musculature is going to fire from 0 to 90 degrees as far as the glenohumeral or shoulder joint. And then once we go above 90 degrees, the muscles of the upper back, like the trapezius and things like that, will help take over. When we look at internal versus external rotation, if there's going to be a deficiency, and we'll speak about this later, it's going to be an internal rotation. It should be equal. We should see a 90 degrees of external and internal rotation whenever we're measuring someone. So when we're talking about the shoulder joint, we're going to be talking specifically about just the movement of the head of the humerus inside of the glenoid fossa. When we're talking about the shoulder girdle, particularly what we're really speaking of is the movement of the scapula. So when the shoulder joint is going into abduction, we see that during abduction, we're going to have an upward rotation of the scapula. So we're going to have the scapula, the inferior angle of the scapula, rotating laterally. When we see adduction or adduction, moving the arm back towards the midline of the body, we're going to see the inferior angle of the scapula rotating in a downward fashion. When we go into flexion of the shoulder joint, we're going to have both elevation and upward rotation. So again, the inferior angle of the scapula will be rotating out towards the outside or the lateral portion of the body. When we come back to extension, we'll see first the depression of the scapula and then downward rotation. When we see internal rotation, the actions are going to be opposite. So when we internally rotate the shoulder joint, what we actually see is the abduction or the protraction of the scapula. So when I move my hand in external rotation or the shoulder joint in an external rotation, I'm moving the hand or the shoulder joint away from the midline of the body, and then again it'll be opposite, and then we'll be retracting or adducting the scapula towards the spine. Same thing is true when we see horizontal abduction. So if we're moving the shoulder joint away from the midline, then what we see is that the scapula moves towards the midline. So it's going to be opposite. When we see horizontal adduction, then what we're going to see is the scapula doing the opposite motion or protracting. Thank you and have a great day.